Hi, welcome to the BHIPP Brief Practical Medication Management of Pediatric Anxiety in Primary Care. My name is Dr. Shauna Reinblatt, and I am a BHIPP consultant and a clinical assistant professor in the Division of Child Psychiatry at the University of Maryland School of Medicine. This is a review for the non-psychiatrist pediatric clinician of the pharmacological treatment options for pediatric anxiety disorders, non-OCD and non-PTSD anxiety, as well as the possible side effects of these pharmacological treatment options. This webinar is meant only as an educational tool and is not a substitute for the primary care provider's clinical judgment. The use of many off-label medications will be presented. The recommendations presented do not indicate an exclusive course of treatment, nor represent a standard of medical care. Efforts have been made to set forth medication doses and choices. It's the healthcare professional's responsibility to check the medication's package insert for each drug for changes in doses or indications. Please call our BHIPP telephone consultation line, 855-MD-BHIPP, for specific treatment-related questions. So when are medications prescribed for pediatric anxiety disorders? We're continuing from the previous BHIPP brief, which described the evaluation of anxiety disorders in children. Non-pharmacological treatments will be discussed in the next BHIPP brief, webinar, and newsletter. Let's assume that we have completed our assessment and diagnosed a pediatric anxiety disorder. What factors would help us make decisions regarding the use of medications to target anxiety disorders in youth? First, optimally, we'd like to see that there are enough symptoms to have a diagnosed disorder, or at least a very strong likelihood of one, in the context of continuing evaluations. 2, the symptoms should be present for a sufficiently long period of time. So, for example, we are referring not just to a few days of worrying about an exam without a prior history of anxiety. 3, significant impairment or distress which affects various areas of function, school, family, social and emotional function, for example. 4, significant differences from baseline in several areas, such as activity, worries, sadness. And lastly, failure of other interventions, particularly if psychosocial therapy, for example, had already been started, but does not appear to be helping to alleviate anxiety symptoms. Now, how do SSRIs and SNRIs work? SSRIs, the selective serotonin reuptake inhibitor, are shown on the right side of the slide, and serotonin is denoted by 5-HT. All SSRIs have some common features. The selective inhibition of serotonin transmitter, which imminently and acutely increases the serotonin in the dendrites, as shown on the left of the figure. Then, over time, the serotonin autoreceptors downregulate and become desensitized. Thus, the brakes, or autoregulation, release the serotonin stop so that it now does not regulate the release at the axon. And after several weeks, this coincides with the clinical timing of improvement sometime into treatment. On the right-hand side of the slide, SNRI'S, or serotonin norepinephrine reuptake inhibitors, combine similar serotonin inhibition with inhibition of the norepinephrine transporter, as seen on the right of the figure. So what evidence do we have regarding SSRIs and their use in pediatric anxiety disorders? One of the studies that is the largest and the largest randomized control trial is a child and adolescent anxiety multimodal study, otherwise known as CANS. In this study, children and adolescents aged 7 years to 17 years with various anxiety disorders. There were several groups: the cognitive behavioral therapy, or CBT group, the placebo group, the sertraline only group, and the combination group of CBT plus sertraline. There were 488 children and adolescents in the study. Sertraline was titrated on a forced titration schedule over the course of the study, which lasted 12 weeks, to a maximum of 200 milligrams daily. They used the Clinical Global Impressions Improvement Scale and the Pediatric Anxiety Rating Scale to rate the improvements. Improvements at 12 weeks are summarized as cognitive behavioral therapy improved 60% at 12 weeks, sertraline 55%. The placebo group only improved 24% of the participants, and the combination of CBT and sertraline was 81%. So you can see that cognitive behavioral therapy and sertraline had the biggest improvement over all the other groups, including placebo, at 12 weeks. This was a National Institute of Mental Health funded study and the first head-to-head comparison of therapy and medication use in anxiety disorders in children. What about the different types of SSRIs? Here, we'll review briefly some commonalities and differences. As we look at the SSRIs, it's important to remember that they're all separate compounds, except the active isomer of citalopram is escitalopram. But other than that exception, all SSRIs are similar compounds yet different. The three most commonly used clinically in clinical practice for children and adolescents are bolded. The three first SSRIs listed on the slide, fluoxetine or Prozac, escitalopram or Lexapro, and sertraline or Zoloft. Although not FDA indicated and are off-label for anxiety use, are sometimes used for anxiety disorders. And the less commonly used fluvoxamine and citalopram and paroxetine are listed as well. Fluvoxamine, otherwise known as the brand name Luvox, is rarely used except for OCD, so rarely used for non-OCD anxiety disorders in children. Citalopram is noted to have QTc prolongation, which limits typical dosing strategies and its use in general for children and youth. Paroxetine, which has nonlinear kinetics and also has a short half-life, limits its use. And as we will review on another slide, fluoxetine is FDA approved for major depressive disorder in children over age 8 and OCD, but not non-OCD anxiety disorders. Escitalopram is approved for major depressive disorder, 12 and up, and sertraline is approved for OCD. But although these three SSRIs, fluoxetine, escitalopram, and sertraline, are often used in clinical practice, again, they are not FDA approved for non-OCD anxiety disorders. And just to continue to review the similarities and differences, we do know that in terms of similarities, there are similar mechanisms of action, which we've already reviewed. Efficacy, we've reviewed one study of several, looking at how SSRIs are useful and efficacious for treating pediatric anxiety, as well as, in general, their once-a-day dosing. But in terms of differences, there are two main issues that I will highlight. One is the duration of effect, and the other is the hepatic metabolism. So in terms of duration of effect, a medication such as fluoxetine with a very long duration of action may impact your choice. For example, if you have a patient who tends to be non-compliant and may not take the medication every day, and you want to avoid having withdrawal symptoms or discontinuation symptoms, it may be optimal to have a medication with a long duration of effect or a long half-life. However, if side effects are developed, you may not want a long duration of effect, and you may want a drug with shorter duration of effect, such as sertraline, for example. In terms of hepatic metabolism, there are differences between the SSRIs in terms of the CYP450 isoenzyme effects as well. The medication escitalopram, for example, has very few interactions in terms of hepatic metabolism. And so if you had someone who was theoretically on many medications that could interact, that might be the SSRI of choice. The following slide highlights the fluoxetine SSRI, otherwise known brand name Prozac, which is not FDA approved for anxiety. However, there is good evidence, level B evidence, and is, again, FDA approved for OCD. Sertraline has similar indications and evidence, and then fluvoxamine, which we won't be covering in detail during this webinar, also has similar indications. Many of the SSRIs I will highlight are often available in a generic form as well. Additionally, the FDA requires, in general, when medications are approved, that there be one diagnosis for approval, typically. And again, as discussed in the previous BHIPP brief, children often have several anxiety disorders together, particularly younger children, and so it is sometimes difficult to tease those out and difficult also to get FDA approval. However, there is very strong clinical evidence and data to support the use of SSRIs first line, although off-label. Typical daily doses for sertraline and fluoxetine are shown here. These are typical dosing strategies for two common SSRIs. As previously alluded to, dosing typically starts low and the medication is slowly titrated to monitor for side effects that may develop, as we will soon discuss. For sertraline, a typical start dose for a child under 12 would be around 12.5 milligrams total daily dose daily. The recommended follow-up would be in 1 week or perhaps 2, and then with regular follow-up thereafter, and increasing typically by the start dose every few weeks. This would vary according to the clinical side effects and tolerability of the medications. We go slowly, meaning that if there are no imminent safety concerns or side effects and the medication has not taken full effect, it may take some time for us to titrate. So we slowly titrate the medication and it may take up to 4 to 6 weeks for the dose to take full effect. A possible dosing strategy for fluoxetine in youth is also indicated with a start dose of 5 to 10 milligrams, depending on the size and age of the child and the clinical status, as shown in the table. The typical goal is 20 milligrams daily, although as indicated, the maximum possible is certainly higher. However, typically we do not need to go to the maximum total daily dose. These are suggested possible daily doses and not meant to dictate every patient's care. In terms of the SNRI'S, or serotonin, norepinephrine reuptake inhibitors. There are two main SNRIs that we use in youth. One is VENLAFAXINE, and the brand name is EFFEXOR. The generic DULOXETINE is also known as, in terms of the brand name, as CYMBALTA. CYMBALTA or DULOXETINE is FDA approved for generalized anxiety disorder in children aged 7 to 17 years. So, in fact, DULOXETINE is FDA approved for generalized anxiety and is the only medication at this point FDA approved for generalized anxiety in pediatric patients, as we will now discuss. DULOXETINE, or CYMBALTA as brand name, is an SNRI, and we have previously reviewed the mechanism of these briefly. It is the only FDA approved medication. However, it is generally used second line for the reasons we will now discuss, although it could be used first line as well. So, in terms of side effects, DULOXETINE has very similar side effects to the SSRIs, which will be discussed in a few minutes. However, there is also possible somnolence, and it may increase the heart rate and blood pressure, possibly through the noradrenergic effects, although it's unknown. Rarely, there may be associated liver damage, skin reactions, bleeding, and visual problems. Thus, monitoring the blood pressure and pulse is important, and in addition to the typical monitoring that we use for SSRIs, and we'll review soon. Again, although there is strong evidence for SSRIs, they are off-label, and DULOXETINE is the only FDA-approved medication at this point. But its use is limited by side effects and less overall evidence. Typical daily doses may start at 15 milligrams, sometimes 30 milligrams. And this slide shows a possible maximum of 60 milligrams, although often a much lower dose is required. And again, we tend to follow the recommendation of starting low and going slow. A meta-analysis actually found the likelihood of treatment response in youth greater for SSRIs as opposed to SNRIs, with a 1.9 odds ratio. So, in summary, although the SNRI DULOXETINE is FDA approved for generalized anxiety, we need more head-to-head studies, and SSRIs are still considered to be first-line treatment in general for typical childhood anxiety disorders, which also inherently typically include more than just one anxiety disorder. EFFEXOR, the brand name for VENLAFAXINE, we will briefly review. Again, this is an SNRI. This SNRI behaves like an SSRI at lower doses, and at higher doses has more of a noradrenergic effect. It may be used for depression and sometimes anxiety. However, side effects may limit its use. The side effects we see are similar to SSRIs, but we also see decreased appetite and sometimes somnolence. There may be hypertension, and in particular diastolic hypertension, and tachycardia. And there may be significant discontinuation syndrome symptoms. Sometimes patients may appear to have panic attacks continue or even increase, and it's unclear whether this could be a side effect or simply their anxiety. So the take-home points are to monitor the blood pressure and pulse if this medication is used. This is not FDA approved for pediatric anxiety, and there's much less evidence for this medication than DULOXETINE or any of the SSRIs. Additionally, there's the risk of very unpleasant withdrawal, and some anxious patients may not tolerate the medication. In general, as we've discussed, we start low and go slow. The effectiveness of medication with any disorder can vary, and response is not usually 100%. The effect size generally for anxiety is around approximately 0.7, with a reminder that stimulants have been shown to have an effect size between 0.8 and 1. The therapeutic dose and maximal benefit may take 48 weeks to reach. To enhance compliance, we need to keep in mind possible side effects and all the other factors which led us to choose the particular medication that we have discussed with the patient. Also, certain compliance discussions may include practical aspects such as keeping the medication near their toothbrush or in a regular place, discussing with parents, and really getting everybody on board with treatment. It's important to remember that in treating pediatric anxiety, we need to discuss the risks, benefits, and alternatives, so obtain informed consent with the guardian or parent, as well as with the youth, and to document this. So, when discussing the informed consent, it's important to review possible side effects or adverse effects of medication. In terms of SSRIs, the most common are gastrointestinal pain, or even more likely, diarrhea or nausea. Sometimes some will obtain headaches. However, other than these common side effects, there are other less common possible side effects. And these side effects may also occur because anxious kids are more aware of their bodies and thus may be more sensitive to side effects overall. In terms of also other possible adverse events, many are listed on the slide that may occur. Activation, which we'll briefly review. Apathy, which typically occurs after some time and is described further in the BHIPP newsletter on this subject. Bleeding or nosebleeds due to possible, occasional, and rarer platelet adhesion. Problems on SSRIs with some children. The discontinuation syndrome or non-emergent withdrawal. Hypomania or mania. Synergy with alcohol, which can make using alcohol very which can make using alcohol something that's not recommended in conjunction with SSRIs. Serotonin syndrome, and which we'll discuss in a minute, and sexual side effects such as decreased libido and orgasm, and suicidality. Serotonin syndrome is a rarer possible adverse event, but because of its possible morbidity, it is important to recognize in patients on SSRIs and SNRIs. Typically, it is seen and the patient has an increased risk when there's more than one serotonergic medication used. Typically, the gastrointestinal symptoms last several days with marked diarrhea, perhaps nausea and vomiting, typical fevers or sweating, and autonomic symptoms of pulse and blood pressure changes. Typically, there will also be a change in mental status. So if there's over 5 days of diarrhea, fever, and a change in the patient, this is something more urgent, although rarer, but something to know about. Activation, who's at increased risk? So we typically see activation more in younger children aged 6 to 12 in particular. What are the symptoms to monitor for? Symptoms of hyperactivity or increased activity, restlessness, impulsive behaviors, and disinhibition. These are typically changes from baseline. They typically present at the beginning of treatment, so the youth most at risk besides younger children are those who first begin SSRI treatment, and also with increased dose. So the titration may affect the risk for activation, and there have been some studies that have suggested possible increased plasma levels, although this requires further investigation. However, what can we do? Well, if you feel that your patient has activation, you may need to slow titration and sometimes stop the medication. How do you differentiate activation from mania? Among other things, mania or hypomania is rarer, and you see typical manic symptoms, such as decreased need for sleep, and possibly psychotic symptoms and manic mood symptoms as well. Antidepressants and suicidality. Controlled clinical trials have reported an association between antidepressant use and an increased rate of suicidality, which is a term encompassing suicidal thoughts and behaviors. It's unclear whether this finding of suicidality might be related to activation or not, although there's been some papers written to this effect. There is a black box FDA warning because of the 4% incidence in children and adolescents on SSRIs when they pulled all the studies versus 2% of those who took placebo. A later study by Bridge et al. Found a smaller 0.7% difference, which amounts to roughly 1 in 133 treated patients. So this was followed by a decrease in prescription rates, and subsequent studies have noted a concurrent increase in suicide attempts, which means that although this is a rare possible adverse event, it's important to discuss with the patients and their guardian or parents, specifically with regards to the benefit versus the risk, and to monitor closely for any emergent suicidality. Discontinuation syndrome, which is colloquially known as withdrawal, mainly consists of flu-like symptoms, gastrointestinal symptoms, dizziness, vertigo, sleep disruption, tingling, and even some report electric shock type sensations. There may also be mood changes and increased anxiety or agitation. Thus, it's important to slowly and gradually taper if possible, particularly the shorter acting SSRIs or other medications in this family, and SNRI'S as well. A 9-year-old girl presents with her mother, who complains that the child tantrums when prevented from sleeping near her. The girl worries about mom, school, and money daily for the last year and has had stomach aches and headaches with a generalized anxiety diagnosis. She's been in therapy for at least 6 months, and her symptoms are still very disabling. She has no significant past medical history or medications. You decide to start a medication to target her anxiety disorder-related symptoms. Which one of the following medications would be your first choice? A, sertraline, 12.5 milligrams daily. B, quetiapine, 12.5 milligrams daily. C, methylphenidate, 5 milligrams daily. D, paroxetine, 5 milligrams daily. Typical suggested answer would be sertraline, 12.5 milligrams daily, or answer A. Sertraline had a head-to-head study in the CAM study, as we discussed, and has good evidence for anxiety disorders in children of the age mentioned. And the dose that's shown might be a typical starting dose. Quetiapine would not be a medication we would use first line as for an anxiety disorder, or even at all. Methylphenidate is a stimulant medication, which also would not be indicated if we're trying to target an anxiety disorder, and paroxetine would not be used in a 9-year-old girl and would not be first line or used in this vignette. So in summary, treatment with pharmacological agents can greatly improve the level of functioning and quality of life of patients with pediatric anxiety. There are many effective pharmacological treatments for anxiety that can be initiated in the primary care provider's office. SSRIs are generally the first-line medication for anxiety, again used in combination with cognitive behavioral therapy, which will be thoroughly reviewed in the next BHIPP brief and newsletter. The SNRI duloxetine is the only FDA-approved choice for pediatric anxiety, specifically for generalized anxiety, but is limited due to it's a new FDA approval and due to side effects and clinical use as well. So we monitor closely for side effects. We start low and we go slow. And we use in conjunction with non-pharmacological treatments. Thank you.